All right. Good afternoon. Welcome to this special workshop with Lisa Murdock. Let me just give you a little bit of background, but for those who don't know me, all you have to do is remember I'm Sandy's husband. I mean, that's the title on my name badge, Sandy's husband. All right, so regarding Lisa, over the past 23 years, Lisa has worked in pediatric acute care hospitals nationwide and in Puerto Rico. Lisa began her journey in anti-trafficking efforts in 2014 after meeting a survivor in the community. That meeting inspired her to expand her work to include exploitation and human trafficking in healthcare education and to implement comprehensive, multidisciplinary, evidence-based protocols for inpatient pediatric hospitals. Lisa believes that healthcare providers, specifically nurses, are uniquely positioned at the front lines of patient care to identify, advocate, and improve healthcare outcomes for at-risk individuals or those already being trafficked. She is the co-founder of Revest Medical Experts, which provides healthcare providers and institutions with the necessary tools to improve their knowledge, recognition, response, and prevention of violence, exploitation, and risky behaviors amongst their patients and families. So welcome, Lisa Murdock.
Thank you, Gene. I appreciate that. Do you guys mind if I walk around a little bit?
Oh, please do.
Okay. So I've been a pediatric nurse for 24 years. I started my career, come on in, at the bedside, 12-hour shifts, clinical work, and I was working as a travel nurse, so I've been all over New York, Boston, up and down the coast, California, Puerto Rico. Oh, by the way, I'll do it in English, but if anybody has questions in Spanish, en confianza, soy media boricua, okay? So I'm in the community. I moved to Orange County, and I'm like, I want to, plant roots here. And I was volunteering as a court-appointed special advocate. And I had met a survivor who was doing a training on human trafficking and was talking about intersecting with healthcare while she was being trafficked, including as young as 12 years old. She had a huge tattoo. She was branded by her pimp at 12 years of age, and nobody picked up on it. So that was like one of the biggest things that really inspired me to do a better job for the people in my community. So started doing every training, every webinar, Heal Trafficking's Train the Trainer, working with survivors within the community for years. And then as I started doing more research and working with healthcare providers, I also found that healthcare providers needed to be empowered to do. Do you have a question?
How did nobody pick up on the...
Yeah, I will definitely get to that. We're going to go through all those barriers throughout this presentation. So I met so many healthcare providers that are like, I knew I was missing something. I felt like something was off, but I didn't know how to ask those questions. And I just want to be able to do a better job. And that includes not only nurses, but even trauma surgeons, like trauma surgeons that I work with at Mission Hospital for years that are like, I need to learn more about this and asking those questions and learning about those red flags. So that's basically how I got my start in anti-trafficking efforts. Don't have any conflicts of interest to declare. We only have 45 minutes, so these are kind of our lofty learning objectives, but if you could just be able to describe the scope of human trafficking in the US and locally and how it really relates to the healthcare setting. Many people go from the prosecution angle and there's not a lot of people that really focus on the healthcare setting. Being able to identify the health impact of exploitation, being able to identify 3 red flags that are common in the healthcare setting. Because what it seems on the outside, on the street, or in a drop-in center or nonprofit might look different in healthcare. And then also be able to recognize the need for evidence-based practice and survivor-driven approaches. And this is going to be the nerdy part of my practice because yeah, it's great to learn all of these things, but who's going to write the policy? Who's going to be able to go forward and be able to create this sustainable approach? Why is this response so important? So as I was doing a research study in Orange County, I wanted to know, not from other experts or clinical people, but from survivors themselves, what was your healthcare experience and what can we do to make healthcare better? I wanted to hear from them. So during one of the focus groups, one of the survivors said, I deliver in 5 days. So she was pregnant with her second child. and said, I don't go to the doctor when I'm supposed to. I went the first and third trimester, but I skipped the second. So even for my daughter, if she don't feel good, then we will figure it out at home because I don't want them. I don't know. I don't feel comfortable with doctors and nurses. I don't feel like it's a safe place. It would have to be something that's like dire need that I know I cannot Wikipedia and try to figure it out for me to be like, okay, I'm going to take her to the hospital. So for me, that's really important in making sure that we're creating a safe space so people feel comfortable in order to engage with healthcare so we can create better outcomes for everybody. So what is the scope of human trafficking and exploitation? There are federal anti-trafficking laws. You know, for healthcare, it's just really important, especially as you're building policy, that you at least know how to define it. When I started at my institution, they had a policy on victims of violence, but it literally said sex trafficking equals exploitation. It didn't define it. It didn't talk about labor trafficking. I think this is important. So the Trafficking Victims Protection Act, which you'll hear referred to as the TVPA. So if you hear people referring to the TVPA, this is what they're talking about. It was originally enacted in 2000, but has been reauthorized multiple times. And it gives us federal definitions. So for both sex trafficking, labor trafficking, I want to point out, does anybody work in pediatrics or plan on working in pediatrics with people under 18? Maybe, right? Proof of force, fraud, and coercion is not required for survivors under 18. So if they're exchanging something of value, a place to stay, money for sex, you don't have to prove force, fraud, or coercion. They don't have to have an actual trafficker. So I'll explain in one of the case studies, I had a youth that was coming in for an eating disorder. She was exchanging sex for a place to stay and for money with her friends in LA. That falls under those legal definitions. So if you look at the prevalence, this is based on Polaris. And I just want to say, when you're looking at data, we all need data, right? To be able to say, okay, we definitely need to put more efforts in this. So we need the data to kind of prove we need to keep going forward and creating something sustainable. But it's only the tip of the iceberg. So a lot of this data is only based on survivors and people with lived experience who are actually identified. So it's not the scope of the whole problem. But the US has a very obviously high level of trafficking. Many people think it's a border issue, it's an international issue, but this happens here in the United States. And as you can see here, minor trafficking begins early with over 4,708. California in particular, how many people are from California? Like the majority. California has the highest state with the most prevalence, followed by Texas, Florida, and New York. Some of this can be seen because of the high populations in these states. The other one is because of, high immigrant populations, but also agriculture and other industries that kind of creates this prime environment for trafficking. This is from Orange County. This is from the last report. Orange County puts out a report every 2 years regarding how many survivors were identified and assisted. 37% were under 18 years of age. And if you look at the breakdown, minor victims of sex trafficking, 10% were under 13 years old. 35% 14 to 15 years old, and then 55% were 16 to 17 years old. So I just want to point out that this does affect the pediatric population as well. In addition to that, if you look at the data from the task force from 2015 to 2022, 70% were even Orange County residents. So I think that's really important to point out. It happens in affluent communities as well. The scope of labor trafficking. So healthcare providers are not immune to the media portrayal of trafficking, right? Many people will relate human trafficking. What do they think of? Sex trafficking. Without knowing the scope of labor trafficking, if you look at global data, you can see almost 25 million people have been identified as victims of some force of forced labor. Over 15 million alone were living in forced marriage. 25% of these were children. So it affects youth as well. There is a lack of data-driven research and barriers. Patients are reluctant to disclose out of fear or mistrust. Providers might not have the time to actually build a rapport to create that safe space. And then as you look at systemic inequities, global disasters, pandemics, economic inequities, it creates the barrier and the environment for these things to proliferate. These are some of the typologies. I know many people, the first thing that comes to your mind could be agriculture, manufacturing, healthcare, and beauty. A lot of people don't realize even healthcare can be an environment specific to trafficking. There have been people, through fraudulent means saying, come to the US, we have this great job for you, and then end up becoming trafficked within skilled nursing, for example. So all of these typologies have been affected with labor trafficking. Forced criminality. So has anybody learned about forced criminality or, within the scope of human trafficking?
Heard of it.
Okay.
Through TV.
Yeah. So this can be kind of controversial when you're talking to healthcare providers and other people, that are not aware that a trafficker may also force survivors or victims at the time of their exploitation to commit a crime or multiple crimes during their period of exploitation. And so due to this could be drug sales, theft, shoplifting, just to name a few. And they're often subjected to crimes for these crimes that they were forced to commit. And they have a record and they're prosecuted for these things. The trafficker can also use these to manipulate them into staying. Like, I'm going to tell you're going to get in trouble for that. I still have survivors that even after their period of recovery are still thinking of themselves as prostitutes. Well, I was a prostitute and you can get in trouble for that. Because nobody kind of encouraged them and kind of educated them along the way. You are not at fault. This is something you are forced to do. Even with that prolonged period of victimization too, remaining with their traffickers because they're afraid they're going to get in trouble does happen because of forced criminality. Also, one more thing about forced criminality as well. I've had youth that were in the hospital with gunshot wounds and other injuries, or tattoos that were branded by their traffickers, saying when they got to the hospital, the first thing they asked them is, what gang are you from? Are you from a gang? What gang are you from? And that survivor said, why do you think because of my injury that I'm involved with a gang? On the flip side of that, there are people who are in gangs or have been exploited by gangs. So even if that is the situation, they still deserve care. You still need to ask those questions around the sensitive topics because you don't know how they got there, why, their injuries, and what their backstory is. So these are some of the notable changes from the pandemic we learned about yesterday. The increase in online recruitment during the pandemic went up 22%. So in the past, common places for recruitment might have been foster homes, group homes, schools, strip clubs, things like that. During the pandemic, the internet online recruitment increased. You can see here even Facebook and Instagram. So many people might think of these as like benign social media platforms that everybody uses, but traffickers are online where vulnerable people are and use this as a means of recruitment. And then the other interesting topic when it comes to exploitation is knowing familial trafficking does exist. That was increased by 47% from 2019 to 2020. 42% were brought into trafficking by members of their own family. That's why it's so important as healthcare providers to make sure that you're separating, that youth or your patient from whoever they're coming in with. This was a landmark study back in 2014. Normally, we wouldn't be talking about studies that were done over 10 years old, right? But I think this is really important that for 10 years, research and healthcare providers have been looking at where human trafficking and healthcare intersect. This study was done where up to 88% of survivors reported seeing a healthcare provider during their period of exploitation. You can see here the majority were seen in the ER. A follow-up study to that in 2016 by Chisholm Straker, 68% reported intersecting with trafficking, but it's really with healthcare while they're being trafficked. What's interesting though, you can see ERs and urgent care being kind of like the most predominant place that they intersected with, but even primary care visits, dentists, pediatrician's office, So this really spans the whole scope of healthcare facilities. Some of the risk factors, so people who are housing insecure, youth that run away, youth that are kicked out of their homes, foreign nationals, past history of violence, so both physical violence, sexual violence, and neglect, having social factors, poverty, social isolation, having a lack of support, lack of friends, family members, cultural, ethnic differences, gender identity differences, all of these things make somebody vulnerable to a trafficker who is looking for somebody in those situations. There's a couple case studies kind of mixed in here, but I think it's always important when you're talking about healthcare and human trafficking to talk from experience about how does this apply to us as healthcare providers, or how do we help people with lived experience kind of navigate this crazy world of healthcare. So one of the survivors had said she had caught multiple STIs. She had seen healthcare providers. She had been called frequent flyer. She said, I'm what they call a frequent flyer. I had been in there multiple times, which, kind of breaks my heart because now somebody is labeling themselves as a frequent flyer based on what they've heard through other healthcare providers. She also said, I had multiple partners, and the nurse did seem kind of concerned about it when I reported having multiple sexual partners. She seemed concerned, but she didn't ask me any more questions. Like, was I involved in anything? The other one, and this is pretty heavy, and I'll kind of give you the synopsis. So she was trafficked young. She was trafficked starting at the age of 4 by a family member. When she was 11 to 13, one of her systems, because if you learn about human trafficking, kind of like the HT 101 of it, people are forced to work 24/7. You're not allowed to have any days off. You're forced to work for your trafficker. That includes when you're menstruating. So when she was menstruating, she would put sponges inside her to stop the blood. And as you can see here, she's like, that was my way of getting things done, especially without getting in trouble. And I'm pretty sure that I'm not the only little girl who has thought of that. We have to do what we have to do. So there were times when she'd shove makeup sponges, tampons, to the point where she lost so much weight, she said, I got really pale and almost went into shock. So when she went into the hospital, of course, as a healthcare provider, you're like, oh, toxic shock syndrome. She was admitted for toxic shock syndrome because it was in there for too long. But she wasn't recognized in the hospital. So it's really important to know some of the things that are happening, the diagnoses and the experiences that these patients have an underlying story, and to ask sensitive questions. Another situation, and this kind of goes under, kind of that federal definition of what human trafficking is without having a trafficker present. So this is a minor female. She was brought in for an eating disorder, and she came in with a backpack with taser and condoms in it. And the first thing the physician was like, I knew that was a prostitution backpack. So it's really an opportunity for education, right? Like, this is not a situation of prostitution. This is an exploitation situation. She reported to one of the CNAs, hey, I'm going to LA. I'm exchanging sex for money, a place to stay with my friends. And it's also interesting that when you're thinking about educating clinicians, it needs to be everybody, not just the nurse, not just the physician or the surgeon. It has to be everybody. In this situation, she talked to the clinical associate because she was closer to her age. So she had built that rapport for her and she felt more comfortable. So whoever they feel comfortable with, absolutely ask those questions. And if you don't know what to do, then ask somebody else, whether it's a nurse or a charge nurse or somebody else in your facility that's more comfortable with human trafficking questions. I will say another thing to watch out for when you're a healthcare provider is that not everybody's going to come in and disclose right away or disclose at all. There's going to be fear surrounding that, which I'm going to get to in these slides. But she came in angry, hostile. She's like, I'm not eating this. I'm not eating that. She was banging her head up against the tub wall. And what usually happens, does anybody work? I know, Shamra, you work in healthcare. Do you know what happens if somebody's hurting themselves or somebody else? What happens?
That's what a mental facility.
Well, if you're in the hospital and you're combative and you're fighting and hurting yourself, go ahead.
I feel like you
Restraint.
Get security and restraints.
Exactly. That's what's going to happen. They're going to end up in 4 points. In that situation, knowing kind of underlying what was happening, and sometimes you can diffuse a situation and sometimes it's not. Sometimes it has to be, medication. Sometimes people do end up in 4 points. But the important thing to know is to try other means to diffuse the situation. I had the time, so I ended up sitting with her on the bathroom floor. I put pillows underneath her head and earphones. So people were having a fit because she was listening to music that had explicit lyrics. And I was like, who cares at this point? Like, I definitely don't want the 4-year-old next door hearing, the explicit lyrics, but let her put headphones in just to kind of diffuse that situation. So just some things to keep in mind as you're going forward as a provider. So there are multiple challenges with identification. Providers have lack of awareness and accurate education on human trafficking. Sometimes providers are still seeing things that they've seen in the movies or on social media, or they've been educated by somebody that's not in their discipline, so maybe law enforcement or somebody else that doesn't really know the presentation when you come into the hospital. So they have those misconceptions. People are kidnapped. If you look at the data, it's like between 1% and 4%. Traffickers do not need to kidnap people. They can trick people into either, being online, thinking, I'm the same age, and then through tricking them, right? So, they're targeting the vulnerable populations or kind of tricking them into either sending the nude photo, as we learned yesterday, and saying, hey, if you don't do this for me, I'm going to send this to everyone. Or kids that were recruited through foster care who were recruited through, being vulnerable, and that trafficker saying, nobody cares about you. Nobody's looking for you. I'm the only one that's going to be taking care of you. I'm the only one here for you. And so they feel like this is the only person that's taking care of me, and they end up getting traumatized in that situation, and then through multiple reasons have a hard time leaving that situation. Unless you know all the presentations about accurate human trafficking presentation, people are still going to miss it. Inadequate screening. So many people don't know how to ask the sensitive questions. There are validated tools for both the pediatric population and adult population. Are there a plethora of them? No, there is not. There's even less comprehensive tools that include sex trafficking and labor trafficking and just high-risk behaviors. This is the reason why myself and Dr. Corey, we created our own screening tool for their pediatric population, because we wanted to do sex trafficking and labor trafficking, but we also wanted to include high-risk behavior so we can prevent those vulnerable in these situations from becoming trafficked in the first place. So, having a comprehensive screening tool is important. Scarcity of response protocols. I was talking to Chambray about this yesterday, in having that algorithm. Like, when people are working in healthcare, it's super busy. Like, I feel for healthcare providers. I've been working for 24 years at the bedside. It's busy. You have multiple diagnoses. You have people coming in with sepsis. You have people that go through the windshield of a car. You're trying to stabilize people, right? So unless you're an expert in human trafficking and you're kind of up to date on all your education, when people walk through your door, how do you know how to respond? You need a policy and an algorithm so everybody knows who to call at what point in time. And it needs to be for the pediatric population and adult population. Because if you're working for the adult population, there's no mandated reporting laws. But in pediatrics, you are going to have mandated reporting laws. So there's some communication around that as well. Lack of data gathering and sharing. So currently, there is no centralized database to kind of gather all this information, and that includes in hospitals. So if they are not educated accurately, completely, they don't have a response protocol or a policy, how do you expect them to gather data, right? So once you're kind of instituting this comprehensive policy and program, it needs to include data gathering so we can keep this program sustainable. Survivor related, so many don't identify as a victim. They've, believe or have been told that they're responsible for their actions, so they could get in trouble with the law. Even within my own study, the majority of the survivors were afraid of law enforcement, afraid of getting in trouble, afraid of the healthcare providers judging them. They felt ashamed. They didn't want to be seen. And, all of these things lead to a fear of not only law enforcement, but also healthcare providers and a lack of trust. So that's why you have to take time to really build that rapport. Also, youth, especially under 18, have less access and fewer resources, just in general, like whether it's finding transportation or a place to live or jobs. These are some of the red flags. So if you look at behavioral health signs, sometimes lack of emotion, anxiety, wringing of the hands, kind of shaking of the feet, nervousness, hypervigilance. So if you're doing kind of like your admission assessment, and I'm guilty of this. So, I work really fast because I want to get somebody stabilized. So I'll go help, I'll do vitals, I'll get the critical care sheet, we'll be, doing an assessment, people will be coming in and out to try to help each other. But for somebody who has a fear of every person coming in that room, that's just going to increase their anxiety and their hypervigilance. And so if you're seeing somebody looking up at the door and getting really nervous every time somebody walks in the door, make sure that you kind of assess everybody's individual needs and limit the people coming in and out of the room. Burn marks, cutting, a lot of history of suicidality, sexual health signs, multiple STIs and sexual partners, as we already talked about, toxic shock requiring to work even when you're menstruating, identification issues, location status. So I've had many survivors, and I know people see this on TV, so I've had healthcare providers thinking that the trafficker is always going to be accompanying them, and that does not happen in many cases. So I've had youth just dropped outside of the emergency department and walking in. So they might not know where they're at, how they got there, what the neighborhood is, what street they're on, what street they're from. Those could be signs. Having, evading questions, so they've been groomed to not answer these questions, either out of fear of getting in trouble or getting their trafficker in trouble or other people or maybe threats to their family. All of these things are kind of the red flags. I just want to say, though, even if there aren't red flags present, but you're feeling like something's off, it's still worth asking the questions. So how does this impact somebody's health? So acute injuries, broken bones, lacerations, head trauma, concussions, for example, mental health issues, depression, PTSD, having complex trauma, chronic medical conditions. This is what I really want to talk about because I feel like with all of these, it really relates and, correlates with those red flags, but chronic medical conditions. So I've had a lot of youth that either had asthma or diabetes. Were not identified while they were being trafficked. And as young adults, very young adults, have severe and long-term consequences of not having these needs addressed. So I have a youth was diabetic. I have multiple that have kind of these things. But one in particular, diabetic, was not recognized when she was young. She is now on a dialysis list because she was not recognized. Now, going through appointments with her just as a friend and an advocate, I've heard healthcare providers tell her, yeah, you've been non-compliant throughout your childhood with your diabetes, so you're not qualified for your insulin pump, for example. But the survivor doesn't want to kind of explain her history to this person, and that person's not really asking what happened in the past. Changing that cultural shift from what's wrong with you, why are you non-compliant, to what has happened to you that makes it difficult or challenging. So the health impact of trafficking is long-term and has really severe consequences. So now that we know what trafficking is, we know kind of what the scope of it is, what the healthcare impact, now what do we do about it? And I think this is so important because a lot of times people want to talk about human trafficking and what it is, but what do you do next, especially in healthcare? Making sure you have a survivor-driven approach. Not only are survivors experts with lived experience, their willingness to kind of share those experiences with us, they're uniquely equipped to not only let us know who could possibly be vulnerable, but also what can we do to make healthcare better, safety planning. This is going to be really important as you're going through even your own practice, making sure that you use something that is survivor recommended. Many reported, so there was another study that was done with 51 participants talking about their healthcare experiences. Out of those 51 participants, 47% said nobody ever asked questions about my situation. 23% reported not having privacy, which you'd think, oh, it's private, everybody closes the gown in the back, everybody tries to shut the curtain or the door, but still not feeling like it was a private, safe place. So just being kind of cognizant of these things as you start with your own practice or know other healthcare providers, and really being able to establish that. We need to be familiar with their voices in order to make healthcare better. They reported even healthcare providers not believing them and their story and their experiences, and also healthcare providers believing their traffickers over them. So it's really important that we kind of take this all into consideration as we're going forward. Making sure survivors' experiences are equally input with ours. Making sure if you do have a survivor consultant on your team that they are compensated for their time as clinical experts. So communicating with survivors. When someone has experienced complex trauma, how do you think they feel coming into a healthcare facility? Even for other people navigating the healthcare system that don't have lived experience of being exploited, have a hard time. It's scary. People are asking you to take all your clothes off. There's needles. There's procedures. There's anesthesia. Think about all the things that as healthcare providers, sometimes we just take for granted because we're so used to it. We're used to monitors dinging and IV poles dinging and doing things in a certain way that's very natural for us. But they're not for most people. So think about somebody who has been traumatized. Think about that youth who has been exploited, both from her trafficker and then abused maybe even from someone who's buying her, and then she's upset and you're going to put her in 4-point restraints. How do you think that's going to affect somebody? Making sure that you're using a trained interpreter. It's going to sound like nursing 101, but people still don't do this. People are still using family members to translate or the accompanied person. Important to limit your history gathering to your specific role. So if you are talking to somebody and this is positive, this is a human trafficking situation, and you have to call the social worker or CPS in the event that it's a minor, for example, do you need to go forward and ask all the details about what's going on? No. Because somebody else is going to come in and they're going to have to repeat their story again and repeat their story again. So to prevent re-traumatization, just ask your specific questions to your role. On the flip side, if they feel more comfortable with you, then absolutely you can explore those conversations with them. The other important thing, a survivor explained, and if you kind of look at data where many were afraid of law enforcement and other figures of authority, survivor said, I had built a rapport with the physician and I finally, disclosed to him what was happening to me, and they called law enforcement. And then when the police came, he left me. And I felt like he was safe, and then he just left me there, and I wish he didn't leave. So if you've built a rapport with that person and you have to call CPS and law enforcement, give them the option. Is there somebody that you feel safe with? Do you want me to stay with you while they're doing that interview? Using a survivor recommended approach. So these are 5 themes that came out of that research study that I did here in Southern California. Unequal treatment, so both implicit and explicit bias that were experienced from healthcare providers. So from an implicit standpoint, one youth said, when we go in and we've been trafficked and we're in the life, we learn to read body language. We're really good at it. So if somebody comes in and gives us that look, a disgust, and it might not even be to that degree, we feel it, we read it, and we can feel somebody's energy, and that's not going to help us. From an explicit standpoint, one youth was reporting she had her baby. Her baby was with her. She was in postpartum. The father of her baby was with her. She was already in recovery, so she was not being trafficked. She was at a shelter for moms and babies, had an advocate and a caseworker. She said, the father of my baby was with me. He's African American. The first thing the nurse did, she called the social worker. The social worker came in and didn't identify herself to me, but I knew it was a social worker. So people know who people are. Like, it's really important to explain your role and be transparent, even if you see something that you might feel uncomfortable. But she said, because of the father of my baby and my history of trafficking, she thought something was up and was trying to take my baby. So in that situation, they ended up finally calling her advocate and the shelter in which she was staying, and she was confirmed to be in a safe place. That was resolved, but that person then left with that feeling of mistrust. Like they're trying to take my baby because of myself, my history, and the father of the baby. There's multiple barriers to patient care, the red flags and risk factors that we already kind of went over, but also knowing that, they said if we're kind of the wringing of the hands or shaking of the legs, being withdrawn or shut down, look for those small signs and know that we do want to be asked the question. So one of the survivors said, I came in with an attitude and I know how I was acting, but really it was a cry for help. So kind of seeing behind some of these behaviors. Support was listed both from unsupportive and supportive. So unsupportive, being trafficked by a family member, being recruited by a trafficker, not being identified, all of those things. But also from a supportive aspect, one of the youth was shot, not identified in the hospital, housing insecure, living in a park, but she was assigned a home health nurse to come pack her abdominal wound. She was living in a park, so she would tell her home health nurse, meet me at the Jack in the Box, we can do it in the bathroom. So after the second time of doing that, her home health nurse is like, we cannot be doing this in the bathroom. This is not sanitary. Like, you're going to get an infection. Where is your stuff? Where is your stuff? I know that you're living somewhere, and we're going to go get your stuff today, and I'm going to bring you to shelter. And she did that. And the survivor said, to this day, she's my angel because she pushed. She pushed and was like, go get your stuff. It would have been very easy to just keep packing your wound in whatever random spot she asked her to meet in. But just making those, that other effort to connect somebody to the services they need is really important. Did you have a question?
Yeah. So, how do you suggest pushing, but not pushing too far?
I'm going to get to that in a little bit when we do trauma-informed care. Some of the survivor recommendations are here in kind of like this beehive graphic, establishing a rapport. In healthcare, you don't always have time to sit and build a rapport. It's super fast, especially if you're in the emergency room or acute care, but giving people choices. So, hey, I need to do your vital signs. I need to do your blood pressure. Can I do it on the right arm or left arm? If they don't want to sit down. So another survivor was like, that nurse was like, I need you to sit down to do your vitals. And she's like, I couldn't sit down because she had a wound on her butt in the back of her leg. And she's like, no, I'm not sitting down. She didn't have the vocabulary or at the time the capacity to be like, this is what's going on with me. She's like, no, I'm not sitting down. And the nurse pushed and pushed like, I need to do your vital signs. And then, of course, it gets into this heated exchange. And all along, it turns out she had this huge wound. So if somebody is kind of obstinate in kind of those answers, just ask, why don't you want to sit down? Is there something going on? Is something hurting you? Would be a better way? Can we do them standing up? Giving people these micro choices and a little bit of control and power in those interactions. Asking questions about safety and situation. As I said, multiple survivors said, I wanted to be asked those questions, and up to 40% so they weren't asked the questions. Addressing your personal bias before you go in. I always encourage healthcare providers, do your own ACEs. Check for your own adverse childhood experiences. Maybe that's triggering you. Maybe you're not the person to ask these questions, and that's okay. But know your limitations before you go in that room. Address your own biases before you go in. Be aware of the patient's body language. Are they shaking the leg and are they wringing their hands or looking up at the door and you're just kind of ignoring it because you're trying to get your stuff done? Be aware of that body language and kind of give people options. Using a non-judgmental approach, creating a safe space. Trauma-informed care. So this is so important. I feel like it's a new buzzword. Has anybody learned about this, even in school? Yeah. Everybody talks about trauma-informed care. They'll talk about the neurobiology of trauma, how it affects the brain, how it affects your coping abilities, and all those things. Has anybody learned how to implement it? Has anybody talked about how to actually implement trauma-informed care? You have. What, did they use a specific tool or?
It was more like techniques, so never not showing, like, when you're taking care of a patient, you always make sure that they can see you and what you're doing, always narrating what you're going to be doing to them.
Yeah. See, that's a great start. And I'm going to go a little bit further. So I'm going to show you this tool next. But it's really emphasizing that cultural shift between what's wrong with you to what has happened to you. So think back to the 17-year-old with the eating disorder that came in with the taser and condoms in her backpack. When she was discharged, the biggest comment, I wasn't there the day she was discharged, but when I came back following day, so many people were like, you're not going to believe it. All she wanted was her taser back. That's all she wanted. That's all she cared about was her taser back. And I'm like, of course. Did you ever think, what is she going through on the outside of these hospital walls that would really want her to feel like she needed that taser? That was the most important thing to her. Obviously, she's not in a safe space. So really kind of creating that cultural shift within your own practice, but even within the people you work with, just educating on that. Seeing it as a skill. So you might not be good at it at first. It's like putting in an IV or a catheter or an NG tube. The first time you could be super nervous. Like, you're going to put an IV in a baby. Do you think you're going to be great at it the first time? No, you might be nervous. You're going to be trying to figure out like your own technique and how to hold the catheter, how to tape it. I worked in places where I was the only one. Like, it's funny being in California because they have a ratio law. So in pediatrics, there's only 4 patients per nurse. But I've worked on the East Coast, but there's no ratio law. So we didn't have a bunch of nurses to help you hold and put all your tapes and hand you stuff. You had to learn how to put all that stuff really strategically and wrap people, like wrap babies, so you can do everything yourself, right? So I look at trauma-informed care the same way. If you're not good at it, get good at it. Being comfortable with sensitive questions, and if you're not, making sure that you're educating like your manager, your staff. I'm not comfortable asking these questions. Is there somebody else available that can? Social work is another great resource. Building a rapport, practicing, but really it's having a validated tool. So the PAIR tool was created by Heal Trafficking, the Pacific Survivor Center, and Common Spirit Dignity Health. This was validated for healthcare facilities, and the reason why is that it's a quick reference. You can look at this one-page validated tool, and anybody, even if you haven't been to a trauma-informed care training, you can look at it and be like, okay, how do I do these things? If you look at provide privacy, so discussing the sensitive topics alone, making sure you're offering a private setting, but also explaining the limits of confidentiality. So if you do have a youth that's under 18 and you know if they're hurting themselves or somebody else that you're going to have to call CPS, what if you don't tell them that? And they're like, yeah, tell me anything. I'm not going to tell anybody. You're going to break their trust the minute you're like, oh, CPS is called and now in comes social work and CPS. So just explaining the limits of confidentiality. There are certain things, so if you're hurting yourself or somebody else is getting hurt, these are definitely things that we're going to have to report. I just want to explain that to you. So you're transparent up front. Educating people in a non-judgmental way, but also explaining, we ask all people these questions because we want everybody to get the best care possible. Also using visuals, because I know this happens even in my own career. You're supposed to be assessing someone's reading level or education level. People don't have time. So also being able to be like, I always ask people if they can read and write and things like that before I'm giving them educational information. But also just using visuals, having a card with information on it is super helpful. Asking the sensitive questions, allowing time for discussion, but also asking the questions in an open-ended way. You know how many times I've heard people do admission questions like, you feel safe at home, right? Oh, yeah. Yep, I feel safe. So it's really asking questions. And if they do respond with something, just be like, tell me more about that. Tell me more about what's going on. Asking things in kind of that open-ended way so they can share. Respecting and respond. This sometimes can be really difficult because you have to respect people where they're at. So if they don't want to share with you, you can't make them share. Respecting the fact that this is where they're at, they're not ready to share more, and that is okay. Responding in a way where, number one, you're using a trauma-informed, non-judgmental way. Many people in healthcare are like, oh, we practice patient-centered care. Well, that's great, but if you don't know who your patient is, how are you practicing patient-centered care? You have to know who your patient is in order to respond in a way that's going to be appropriate for that specific person. And if it is a survivor and they are going to be discharged, you have to give follow-up discharge information. And it has to be coordinated with that person because they're going to know more about their safety than you do. So can you have a card with that phone number on it? Are you going to have to put it in their phone and kind of disguise it as a wellness number or something else? Asking them what's safe for them to have. Some survivors had said the peeled back ingredients on the back of a hand sanitizer, they're like, oh, I wish I had something like that with the numbers on the back of a hand sanitizer. Something to that effect. But making sure that you're actually giving them those resources they need. And so, being compassionate. So this survivor had said, make sure that person still feels human and they feel humanized even for a moment. Because even just that little second of humanization can make such a big difference. And the entire person's view in the world, like, oh my God, you see me, no one sees me. I walk down the street at half naked at effing 12, no one sees me, but you see me. This was a situation where the survivor explained she was in the emergency department and she saw a nurse taking care of another patient. And she's like, she was giving all the love and care in the world to that other patient. And then she wasn't even my nurse, but she came over to me and she gave me something to eat and a blanket. And she was my angel. So at that point, she just felt like somebody saw her, somebody humanized her at that moment. And she's like, she wasn't even my nurse. She didn't even have to come over to me before the end of her shift. So sometimes just seeing somebody and meeting their immediate basic needs can change someone's world. Okay, this is the nerdy part, okay? So these are the pillars of medical institution response. Awareness is not enough. I was presenting at a huge nursing conference. There's like 194 nurses physically there. There's another 84 online. I asked them, who has ever heard of human trafficking? Everybody's heard about it, whether it's accurate or not. I don't know. I asked how many people have ever been to a training by a healthcare professional who has expertise in human trafficking. Maybe 5 people raise their hand. It's having accurate education and training, knowing what it looks like inside the hospital, knowing those red flags, but also someone could come in with a chronic condition and just knowing those little cues and body language that someone could be presented with is so important. Trauma-informed care, knowing how to implement it, having that in your facility, step one. But is it enough? So everybody knows about human trafficking. Is it enough? What if you have a human trafficking champion in your facility and then they leave and they go to a different job? Is that going to continue? No, you need a policy and protocol. You need a policy to say, this is what human trafficking is, and this is how you respond, and it's in writing. So it's sustainable. It's lasting beyond any one person's employment at any facility. Screening implementation. You want to be able to ask the sensitive questions. Now, ideally, would it be great to build a rapport, not use kind of a checklist questionnaire, and just everyone's an expert on asking these open-ended questions? Of course. But in reality, in life, in multiple healthcare facilities, and data shows that less than 1% of hospitals and institutions actually have a comprehensive protocol, you need to implement a screening tool to help navigate these conversations, to help people ask the open-ended questions that's really going to elicit a disclosure, because people are groomed to evade the questions and they're afraid of getting in trouble. So how can we help people if we don't really ask those questions? Once you've done all this, so now everybody's educated and you have a policy around it and you start screening and asking the questions and your identification goes up, which is a good thing, by the way. Some people are like, oh, that's a liability if we start looking and we're noticing people of human. No, the liability is if we don't notice people and we're discharging people without resources, right? But once you start identifying people, you can't just send them out with no resources for follow-up. You really need to have referral and resources, whether it's a brochure, a piece of paper. You need to collaborate with whoever's in your community. So here we have Waymakers, which is victims assistance, making sure you're connecting people with victims assistance, a drop-in center, a shelter, food pantry, making sure all their needs are met. And then on the back end, collecting the data. So for me, if you would have asked me in my nursing career if I was going to start collecting data and doing research and writing policy, I'd have been like, absolutely not. I am a bedside nurse. But it's necessary because you know what the first thing an institution will ask you? What are the numbers? How many are we seeing? And what are we doing about it? Here's the step for creating that response. We kind of went over this in the previous pillar slide, but identifying a human trafficking champion, and I know everybody, that's the key word now in healthcare. There's the sepsis champion and the asthma champion. Everybody's a champion of something, but you really need that person to keep pushing things forward or else it falls by the wayside because people get busy. Forming a multidisciplinary team so everybody within your institution and departments know about this. Sometimes one unit will have something like the emergency department, but not the inpatient unit. OB might have something, but med-surg doesn't have something. So making sure you have a multidisciplinary team so it's super easy and can navigate through multiple departments within the institution. Providing the education, the screening tool, the algorithm, the resources, collecting data, and then making sure you're following a process so you can see, is our process working? Is our education updated? Is it effective? Many providers, after they go to a training, will be like, oh yeah, I can identify it, but if you actually give somebody a scenario, either written or a video, can they identify it? Sometimes that doesn't happen. So making sure that you're improving your process as you go along. And so just remember, a survivor had said, we're terrified. Every person that walks through the door, we do think it's either a client, a pimp, a friend of a pimp, and we do not know, and then it gets to the point where we're sitting there for so long that we get up and leave. Sometimes we don't even make it past the front desk because it's terrifying. So just remember, everybody has their experiences that they're coming in with, and just remembering where they're at. The response and follow-up, we kind of went through this, but making sure that people are aware that coercion is not used in most cases, or coercion is used in most cases, not kidnapping. Traffickers don't need to kidnap. They're using mental manipulation and coercion to keep people there, and knowing it's not a one and done. So they might be coming into your institution multiple times and using that non-judgmental approach and making sure every time they come in, you're giving them the resources they need at that time. There's multiple challenges to recovery. The nervous system is overwhelmed. It becomes dysregulated. There are multiple things that happen, because of their exploitation, but also because the system's not identifying them and giving them the resources they need over this long-term recovery. And so therefore, the hidden nature of trafficking is really difficult. It's difficult to identify for the multiple kind of barriers we talked about, but survivors have complex needs. So you need comprehensive care to kind of surround the survivor. And they might not need all of these things. Some survivors need substance abuse treatment, but some don't. An interesting point is transportation. So if you think about food assistance and shelter and job training, legal assistance, absolutely. A survivor, it was really interesting, said, transportation was an issue. I was being called non-compliant because if you expect me to take the bus where my trafficker is or the friend of my trafficker is and they know the bus schedule, that's not safe for me. So I couldn't go to my follow-up appointments because I didn't have safe transportation. So just realizing everybody has individual needs that we really need to address. Prevention, online safety, making sure you're explaining online safety to both youth and parents and people in your community, collaborating with everyone in your community, whether it's other healthcare providers, nonprofit agencies, drop-in centers, police department, whoever it is that's kind of on this task force. And if you don't have one in your community, you can always call the human trafficking hotline as well because they can connect you with resources. Thank you, everybody. I really appreciate that. I put a QR code here just for a survey at the end. It really helps me to know what your experience was like, what you would like me to cover, what you didn't want me to cover, what was tough. You answer that honestly so I can improve my presentation. That would be really helpful. Yes, questions?
So some of these survivors said that I wish someone would ask a question or ask me what's going on. In your experience, because I haven't really worked with PEDS patients, when you ask this, what's going on, and they're claiming I wish someone would have asked, are they actually responding?
Well, yes, because in retrospect, right, they wish somebody asked. But when you're actually in the situation, do they want to answer your questions? No. It is difficult. It's not easy. So sometimes you have to approach it, right, delicately after building a rapport. And if they say no, I'll come back. I'll come back to those questions. So for example, I had a youth that was in the emergency department, she was in the pediatric ICU. So the pediatric ICU came to call me to talk to her because they're like, oh, there's multiple red flags. Not one person felt comfortable asking questions. So she's in the emergency department, and this is her history. She was in the emergency department, had a history of a pregnancy. She left AMA. So she left, against medical advice, and then comes back with a suicide attempt through the emergency department, gets admitted to the pediatric ICU. So they're like, she's not pregnant anymore. She's not pregnant anymore. She has a suicide attempt. She has tattoos. She's not asking any questions. What's going on here? So, of course, I go over and I start asking questions, and she's kind of feeling uncomfortable. So then I started talking about her tattoos. Oh, where'd you get your tattoos? Like, I have one too. And then I could learn a lot from that because I learned that it was her cousin that gave her the tattoo. It was not, kind of this other kind of dangerous situation. But then she kind of opened up and it kind of built the rapport. And I'm like, can I sit at your bedside? And then she started telling me all kinds of things. So she got pregnant. She ended up having an abortion. She felt horrible about it. She felt like she ruined her family. She felt she ruined the relationship with her parents. And that is why she wanted to end her life. So that situation was not an exploitive situation, but it's an example of asking the questions, kind of meeting them where they're at, building a rapport a little bit before you get into the other deeper questions. The other thing, too, is using a validated screening tool that actually helps you navigate those questions. Ours is designed so the first part is done on a tablet. Like, how many youth, everybody uses a phone and a tablet. Sometimes they feel more comfortable just answering the questions, right? So we hand them the tablet. If they answer yes or don't know to any of those questions, there's a follow-up page that writes all the open-ended questions, so it helps the provider navigate through that. And then at the end, there's a provider survey. Was it positive? Was it negative? Was it highly suspicious? Is that helpful?
That's pretty cool.
Yeah.
Okay, so I'm towards the end of pediatrics. I'm gonna have to start going to an adult hospital soon. But how do you see this implemented in adult hospitals? Because peds, they do get a lot of attention, at least from what I've seen.
Yeah, we have child life specialists, we have
they're talking about
dogs.
more than adult.
I get that because we have pet therapy, we have child life specialists, we have all kinds of support in a pediatric hospital. And I see what you're saying on an adult unit, especially in the emergency department, it's super fast, right? So let me just click through, and I think that, Chambray, this might help you a little bit. If you don't have this in your phone, you can put this in your phone. There's tons of resources here. So this is the standardization of a patient of human trafficking. This is a sample of an algorithm, and this will be in your PDF. I have other resources as well, so if you contact me, I have a brochure, so if you want to contact me, I can give you resources to other algorithms as well. But it helps you kind of navigate, even in adult units, how to do it, right? And then let me show you. Heal Trafficking has a protocol toolkit, so this helps institutions actually navigate through all the processes that they need. This is a whole list of validated screening tools. So what's quick, what's validated for your facility, especially when it needs to be fast. And it's not going to be perfect. It is challenging. It is hard. You're working in a fast-paced environment with people that are coming from situations that either don't want to ask the questions or are afraid to ask the questions, or people that don't have the time to build the rapport to ask the right questions. So having these tools just gives providers the things that they need to do their job. The pair tools in there. And then this is the pair tool I did, but with the rationale behind it based on survivor experiences. So you'll see that in the PDF as well. So that kind of accompanies it. It's available to everybody. It's being piloted at a children's hospital right now. With this particular one, it's for youth 12 and up. So if you work in an adult facility, you want to use a tool that's validated for an adult population. This screening tool is effective, especially for inpatient, because it needs to be quick. You can't be asking 35 questions in an emergency department or busy, fast paced. So you want to make sure you're using a screening tool, but yes, you can actually hit me up and let me know what you need for your specific situation, and I'm always here to help.
Let's give it a round.
Thank you. Thanks, everybody. Have a great day.
Thank you.